Hello everyone, so I will discuss coronary artery disease. So as you can see here, the objectives or the learning objectives about this concept is to be able to understand the management for the different cardiovascular disorders. And today we will discuss coronary artery disease and to be able to understand the pathophysiology of every disease process, risk factors, clinical manifestations, and interprofessional care management. Make sure you pay critical attention to drug alerts and for each medication to promote patient safety. When you were in nursing pharmacology, you've learned a lot of medications, but today we'll try to just focus on medications that we commonly give to patients who have coronary artery disease. Remember that we'll be using nursing process to guide us to be able to treat or manage patients who have this disease process. So there are different risk factors for someone to have coronary artery disease. Number one would be age. This is very common to male patients, white men, could be genetic. So it's very important for you to look at the past medical history, familial history of your patient, and also check, their lipid panel. So if they're doing their annual checkup, ask your patient, or if there's any records saying that your patient has hyperlipidemia, you have to check that. Or if your patient is a smoker, has sedentary lifestyle, if your patient is obese, and any other psychosocial factors that can affect them developing this disease process. So again, with coronary artery disease, remember we're looking at the different coronary arteries. So here, just a review, this is the RCA. Okay, as you can see, it supplies, predominantly the right side of the heart. And in addition to that, we also have the left main coronary artery, or also known as LCA. This is a big coronary artery, and it's very important. It branches off the circumflex and also to the left anterior descending coronary artery. Okay, so remember, you are paying attention on these coronary arteries and looking at if this patient developed atherosclerotic plaque, because that's what's going on to a client that has coronary artery disease. Now, as you can see, this is the normal coronary artery, and as you can see, there is a normal blood flow in here. While with a narrowing coronary artery, this is when the plaque build up. And again, there's so many factors that can happen why this is happening to your patient. Maybe your patient has a sedentary lifestyle, or maybe your patient is on a high-fat diet. Okay, or it could be genetic to the patient. So as you can see, of course, with coronary artery disease, if there's a plaque buildup, it narrows the artery, and in turn, your patient can develop high blood pressure because the pressure here will, increase. And as you can see, again, we assess our patient. As I told you, this is what you look for. And these are the most common nursing diagnosis to clients who have coronary artery disease. And based on your priority, based on what's given to you, is that would be your priority nursing diagnosis, and you create a plan focusing on that. And of course, you implement, and whatever you implement your patient, you evaluate. Now, these are the diagnostic studies to patients who might have coronary artery disease. Remember, when these patients are coming in for a checkup, most of them may be asymptomatic, no symptoms at all. So as you can see, we always start with H&P, right? And routinely, what is checked to them is their complete blood count, where you will see their WBC, hemoglobin, hematocrit, platelets, you will see that. And then, of course, with BMP is we're looking for their electrolytes level. We're looking at also their magnesium and phosphorus level. And this is just to check if there's any electrolyte imbalances. And hemoglobin A1C, just to check if there's any presence of diabetes. Okay, and uric acid, if there's any presence of gouty arthritis. Okay, homocysteine, this is not routinely done. This is only done if your patient has chest pain, or if it's elevated, that tells you also that the patient has thrombus. Now, this is the lipid panel that we look at. And again, for lipid panel, we look at the cholesterol level, we look at HDL, and from the word HDL, remember the letter H. This means that we want it high because it's a good cholesterol. Well, with LDL, we want it low because it's a bad cholesterol. Okay, we also check their triglycerides, and of course, the fasting blood glucose test is just to check for any presence of diabetes. Now, other tests that can be done to your patient routinely is urinalysis. And again, this is to check, if your patient has any presence of infection, or if your patient has, abnormal urine osmolality. And this is just to rule out that, your patient has a good, urinary system function. And of course, there are many ways to do it. It can be also done by, drawing blood and checking bun and creatinine. Okay, 12-lead ECG, this can be done also routinely for a client that might have coronary artery disease. That's just to check if there's any abnormal heart rhythm. In addition to that, 24-hour urine creatinine clearance can also be done, especially if your patient is hypertensive, and this is just to check if the patient still is able to clear creatinine, because 100% of creatinine should be out in the system. It's very toxic, and there should be a normal level in our blood that it should stay there. Anything elevated, that's not good. It's a sign of, that the kidneys are starting to fail. Another test that can be routinely done to a client that has CAD is echocardiogram. So this is an ultrasound, can be done at bedside, can be done outpatient, and as you can see, it's just to check the ejection fraction of the patient and to check if there's any structural abnormality. In addition to that, we can draw blood also to check the liver function test, and here's the list. And again, to rule out if the liver is not functioning well, and that can be another problem, right? If it's abnormal. And thyroid panel, just to check if thyroid hormones are, hyperactively in the blood or hypoactively. And these are just not very cardiac specific, but these tests are just to identify if your patient has other things going on. Now, other tests here, I already mentioned to you echocardiograms. I'm going to move on to these two. These two are not, are not routinely done. This is just to, do further diagnostic studies. And especially with TEE, this is an invasive procedure. As you can see, patient needs to be sedated. You need consent. Patient needs to be NPO 8 hours before the procedure, because we don't want the patient to aspirate or vomit. And after the procedure, you want to make sure you check the cranial nerve 9 and 10, because that's you checking the gag and swallowing reflexes. Okay. Now we have also stress echo and stress echocardiogram. This is again, assessing how the patient can tolerate activity. And of course, some patients who have advanced coronary artery disease, they might feel that they cannot tolerate it. They might have chest pain. Okay, so remember that before the procedure, they cannot have any caffeine, and they need to have peripheral IV. They will be walking a treadmill, could be, inclined or declined depending on the cardiologist who is assessing this patient. And again, it can be combined with echocardiogram. Now, as the coronary artery disease advances and there's more blockages or atherosclerotic plaque buildup, your patient might develop angina pectoris, and that's a sign that there's ischemia that is going on in the heart. So as you can see here, there are different types of angina. And again, with Prinzmetal, this is a type of angina that can happen at rest. Okay, it's also known as, angina that is from coronary vasospasm. And remember, there's another term called unstable angina, which can also happen at rest. Okay, that's why it's called unstable. Now, with microvascular angina, this is very common to postmenopausal women, while with chronic stable angina, this means that the chest pain is only triggered by activity, whether it's exercise or any strenuous, activities that your patient is engaging in. Now, to treat the patient with coronary artery disease, okay, and even with chronic stable angina and ACS, because I don't want you to get confused, most of the things here that you see is we also do this to patients who have CAD or coronary artery disease. Like, for example, if they are at risk to have high blood pressure, then of course we give them beta blockers, ACE inhibitors, diuretics. So those are the things that we give. In addition to that, because if the patient has narrowing of the coronary artery, there's a chance that, clots might build up. So that's why we also give them antiplatelet or anticoagulant therapy like aspirin, we give that, or warfarin, okay, for that, to prevent that clotting, to keep, clotting mechanism that's going on. In addition to that, if they have chest pain, of course, we have nitroglycerin that we can give to our clients. And if they're smoking, if their diet is very poor, we can educate them about improving that. And of course, in addition to that, we can also recommend preventative measures like flu vaccine, pneumococcal vaccines. Okay? So again, I'm gonna repeat that whatever you're seeing here can be applicable to patients who have coronary artery disease, chronic stable angina, and also acute coronary syndrome. Okay? I already mentioned to you the 12-lead EKG, which assesses if your patient has possible abnormal heart rhythm. And again, remember with 12-lead ECG, this is commonly asked NCLEX question that the patient needs to stay still because you don't want any artifacts. When you say artifacts, that when you look at the rhythm of the patient, it's all over the place. And maybe the reason of that is that your patient is not staying still. If they have a hairy chest, then make sure that you put delipidate it, or shave that area. Okay. Now, patient can also have Holter monitor. This can be prescribed to be done, and the reason behind it is to assess any arrhythmias during any activity. So this is what it looks like, and this can be done outpatient, okay, or it can look like this when your patient is in the hospital. Okay, remember, patient needs to wear it for 24 hours. They don't need to change any activity. They need to log on what specific activities they're engaging in. Let's say 8 o'clock walking for 2 miles, 9 o'clock eating, 10 o'clock taking a nap. Those things they have to put it in logbook. And they should send this Holter monitor in here to the lab, including the logbook. PET scan, this is not commonly done to patients who have CAD unless there's something more than the CAD. And again, this is a procedure, and these are the information that you might need if PET scan is ordered. Again, you will notice that most of the procedures and diagnostic studies for cardiac is that we are avoiding caffeine and smoking because of the nicotine. You will notice that. Okay? I'll move on. Another test for CAD would be coronary angiogram. So coronary angiogram, it assesses if there's any blockages or anything that, that as you can see here, you can see that there's a good coronary artery here, but then at this part, it's not as good, that it kind of narrowed or shrunk. And that means that there is atherosclerotic plaque buildup, or there's a complete occlusion there that is not good. Remember, this uses contrast, okay? And of course, assess the patient for any contrast allergies. And remember, before the procedure, administer beta blocker because it will help to control also the heart rate of your patient and put the patient on NPO, okay? Now, in managing this patient, remember, these patients because of that atherosclerotic plaque buildup that is due to high fatty diet, they will need statins, anti-cholesterol. Okay, so here we're giving, atorvastatin. You can also give cholestyramine, niacin, gemfibrozil. You might not be familiar with them because they are not commonly used, because we commonly use statins. So this is just to expose you to some of this medication that we give. In addition to that, to prevent clot formation, we give them aspirin and clopidogrel. Now, the problem with aspirin is it can predispose your patient to have GI bleeding, because it can really irritate the stomach, and your patient will tell you that they're having a lot of discomfort when they're taking this drug, and that they tend to stop taking it, or they will eat to kind of help with that discomfort. So make sure you assess your patient when your patient is on this medication. And in addition to that, I already told you that we're giving these medications, and check the creatinine level of the patient when you're giving diuretics. Teach them about physical activity, and that is 30 minutes for 5 days per week. That's the recommendation of American Heart Association, and educate them about smoking and alcohol consumption. Okay? And if your patient is hypertensive, you've learned this in nursing pharmacology, that to avoid using any recreational drugs. And for alcohol intake, for women, they're only allowed 1 drink a day, and for men would be less than 2 drinks a day. And for caffeine, about 2 to 3 cups only, because that can increase blood pressure. And if they're taking some of this medication can increase blood pressure. Okay, these are some of the things. So if you have a different textbook, just look for reducing risk factors for CAD, the diet, tips to make diet and lifestyle changes, and health teaching. Remember DASH diet. This will really help our patient who has hypertension. Okay? And as you can see, there's a lot of fruits and vegetables. And let me know if you have any questions. Thank you.